Hello, everyone, and thank you for joining us to learn more about current research from Dr. Weims' lab at the University of California, Santa Barbara regarding diet as a potential treatment for PKD. I am Nicole Haar, Director of Community Engagement at the PKD Foundation, and I will be your host throughout the webinar. We will get started with the presentation in just a moment. Please note that the PKD Foundation does not offer medical advice, and the information shared during this webinar is not intended to be a substitute for consultations with your healthcare professionals. I am delighted to introduce you to our speakers, Dr. Thomas Weins and Dr. Nira Dahl. Thomas Weins is a professor at the University of California in Santa Barbara, where he directs a research laboratory focused on polycystic kidney disease. He received his doctoral degree from the University of Cologne, Germany, and then conducted postdoctoral research at the University of California in San Francisco. In 1999, he started his first independent research laboratory at the Lerner Research Institute of the Cleveland Clinic as an assistant professor. Today, his laboratory studies molecular mechanisms underlying PKD with an emphasis towards developing new therapies. Research from Dr. Weins' lab has led to a better understanding of PKD and led to novel methods to deliver therapeutics specifically to polycystic kidneys. Some of the most recent research has led to the discovery that dietary interventions and commonly available and safe dietary supplements can prevent cyst growth in animal models of PKD. Dr. Nira Dahl is currently a clinician educator and an associate professor at Yale University, School of Medicine, Section of Nephrology. She completed an MD and Ph.D. from Tufts University School of Medicine and then residency and fellowship at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. She has been instrumental in developing the Yale Inherited Kidney Disease Clinical Program and is the principal investigator for several ongoing clinical trials in ADPKD. She is the director of the Yale Nephrology Clinical Trials Program. Dr. Dahl is a member of the Scientific Advisory Committee for the Polycystic Kidney Disease Foundation. Dr. Weims, I'm going to turn this over to you.
I want to welcome everybody and thank the PKD Foundation very much for organizing this webinar. So I titled this brief talk, Ketosis and Crystals, Could Diet Be the Key to Treating Polycystic Kidney Disease? And you'll see, some footage from our beautiful campus here at the University of California in Santa Barbara. All right. Before I start, I just wanted to make sure everybody can access all the papers I'm going to be discussing. So everybody is welcome to go to my lab's website. And it says the web address right here. If you click on the publications link here, you can download all the papers from my lab for free, so you don't need a subscription to the scientific journals. Also, I'd like to invite everybody to join my lab's Facebook group, and you will that way receive news and updates about our research as time goes on. So feel free, if you're a Facebook user, feel free to go here and join us. Another announcement, which I say all the time, first thing is always consult your doctor before changing your diet, before taking supplements or medication, and I think that's very good general advice to always keep in mind. All right, so in today's presentation, I will first introduce sort of the, some of the problems underlying therapy for PKD, and then we'll move on to sort of two diet stories that have recently come out of my lab, and one is titled Ketosis, the other one is titled Crystals, and you'll see in a moment why that is. All right, so the diet story one on ketosis is based off of a recent publication that just literally came out a few days ago, December 3rd, in a scientific journal called Cell Metabolism. And again, you can download this paper from my website. And I'll just summarize some of the key results shown in this paper. Just go back for 1 second. The first author on this paper is Jacob Torres, a postdoctoral fellow in my lab. and I'm not sure if anyone can see him in the background. He's hiding there. So Jacob has done most of the work for this that went into this paper, but you can see there are many other authors as well, many people from my lab, as well as collaborators, including Michael Wiese, who is also the head of the scientific advisory board of the PKD Foundation. Leslie Lyons did some important experiments with cats that I will go into. All right. This paper got a lot of press. For example, there was a research highlight in Nature Reviews Nephrology. There's a news release from UCSB. There's some other press, and you can actually, again, download these articles from our website. They're probably a little bit easier to read because they're more written for lay people. So I would encourage you to go find these papers and take a look at those. The second story, diet story number 2, with the crystal story, is also based from off of a recent paper that came out in October this year in the Journal of Clinical Investigation. And again, first author is Jacob Torres from my lab, along with several other members of my lab. And you might recognize some of our collaborators, including Vicente Torres. Maybe many of you are familiar with his name. And please note, there's no relation between Jacob Torres and Vicente Torres. Possibly, if you go centuries back, there may be family relation, but I don't know about that. Also, again, Michael Wiese is in our paper here as well. And again, you can download this as long as along with the what just happened? Along with the oh, I'm sorry, something just okay. There we go. Along with the press, we got, again, there was a research highlight in Nature Reviews Nephrology and so on. So I encourage you all to take a look at those. All right, so here's our campus, University of California, Santa Barbara. We are sitting in this building right now. And these are the members of my team currently, including Jacob, who's one of my postdocs. I have several grad students, undergrads, working on mostly on polycystic kidney disease. And just to introduce the problem of PKD, as you know, cysts in the kidney are the most common feature, or the most obvious feature of the disease. And these cysts originate from the cells that make up the renal tubules. And as you may know, there's about 1 million tubules in each kidney in humans. And these tubules essentially generate what will become ultimately the urine. And in polycystic kidney disease, individual tubule cells start to proliferate. Apparently, they form these dilated tubules, which then eventually overshoot to form cysts. And there can be thousands of cysts in each kidney. And in the process of growing, as these cysts expand, they're thought to destroy the normal renal tissue, the normal kidney tissue, slowly over time. So the way we and many others are studying polycystic kidney disease in the lab is by using animal models of the disease, in particular rodent models, most typically mouse models. And to give everybody a sort of an idea how this looks like, I'm just showing a slide with some data from my lab. So you can see here a normal mouse kidney in cross-section, and you can see right over here a polycystic mouse kidney. So this is a genetically engineered mouse model with polycystic kidney disease, and you can see all these big empty spaces are essentially the cysts. And one of the sort of early research results from my lab was when we discovered that a particular protein, a signaling protein called mTOR, is activated in the disease, and that an inhibitor, a drug called rapamycin, was very effective in inhibiting cyst growth in the disease. So what we could do is we could take these PKD mice, treat them with rapamycin, with this drug, and the kidneys then look much better compared to the untreated animals. And one way of quantifying this is to measure the two kidney weight ratio as a percent of the compared to the total body weight ratio. And I'm going to show similar slides throughout this talk, where you can see the two kidney weight to body weight ratio, and you can see the cystic animals have these very large kidneys, and if we treat them, treat the mice with, in this case, with the drug rapamycin, we end up with much smaller kidneys, much more similar to how normal kidneys look like. So way back then when we published this data, there was a lot of excitement because rapamycin was already an approved drug for a different purpose. And this led to clinical trials fairly quickly. Unfortunately, the results were disappointing. So this here shows the two papers that came out of these trials. One group in Switzerland, one in Germany, tested this idea of using mTOR inhibitors, and essentially the results were disappointing. There was no clear beneficial effect. In hindsight, the reason why these trials didn't work is likely that in humans, you just cannot use high enough doses of these mTOR inhibitors. And these are very, strong drugs with side effects that just make it impossible to use high enough doses in the long term. So that sort of highlights, some of the challenges for drug therapy in PKD. And we talked about this in a recent review article, which you're also welcome to take a look at. So one of the challenges is that PKD is a very slowly progressive disease, which means that therapy would have to occur over very long periods of time. And that means years to decades. Another challenge is that therapy, I think most people would agree that therapy would have to start early in essentially healthy people that may not have significant problems yet at this point. Which means that in order to have a practical or even an ethical therapy, that any drug would have to have extremely low side effects. Otherwise, you run the risk of making healthy people more sick than they were to begin with. And that is a challenge because most of the drugs that have been tested, by many labs, they affect proteins and signaling pathways and so on that are very commonly present in many tissues in the human body, which means that they often have side effects that can be very significant and may preclude the use of these drugs in long-term therapy. So if drug side effects are the problem, the question is PKD therapy possible without any drugs? So that would, of course, be the perfect solution. And so some of the data from my lab suggests that there may be something to it. And let's jump into the first story, the ketosis story. This story began when we published this paper which came out in 2016. And this was a study sort of initiated by my graduate student at the time, who has since graduated and has moved on to a job in industry, Kevin Kipp. He came up with this idea of feeding our PKD mice less food. So there was actually a scientific reason for it. And he essentially just did it. He didn't, at least I don't remember him asking me doing it, because I would have probably said, this is never going to work. So luckily, he just did it anyway, and found that a mild reduction of food intake slows the PKD progression in this mouse model of PKD that we have been using. And this was a very mild reduction of only 23% less food. The way that these feeding studies are done, you always have a control group, and that's the ad libitum fed group, which essentially means that the mice can eat as much food and whenever they want. We would weigh out, or in this case, Kevin would weigh out to determine how much food the control group would eat. Then he would pre-weigh the amount of food he would give to the experimental food and experimental group, and would give them about 23% less food over time. This mild reduction in food intake had no effect on their normal body weight gain, so the animals were not malnourished or anything like this. And I would not have expected there to be any difference in the progression of their PKD, but there was in fact a very dramatic difference. And I think you can see this here. So here's a polycystic kidney of an animal that was just on a regular ad libitum food intake regimen. And this is in comparison here to the polycystic kidney of an animal on reduced food intake. And you can see a pretty dramatic difference. And again, if we're looking at the two kidney weight as a percent of body weight ratio, you can see the animals on the ad libitum regimen up here, and the animals on the reduced food intake up here. So, we looked at many features of this treatment and essentially published this paper saying that the mild reduction in food intake is beneficial, but we don't know why. We didn't really understand the mechanism at the time. At the same time, another group, it's a Mayo Clinic led by Eduardo Cini, had very similar ideas and had conducted very similar experiments and came up with the same conclusion. They initially tested a 40% food reduction, which is, a bit more severe, but then they've tightened it down to only 10% food reduction, and both of those still worked. So they published their paper at the same time, essentially saying it's working. We also don't know why. All right, well, it's good that it's working. So we would still want to know why. And that's what we have been working on since then. And again, Jacob Torres in my lab led this research, supported by other members of my lab, including Sammy Kruger. And we were trying to find out what caused the beneficial effect in the reduced food intake. Is it caloric restriction? Is it the restriction of a certain nutrient group? Maybe carbohydrates, proteins, fat, or is anything else going on? And the way we figured this out is by noticing a behavioral difference in the mice that are either in the ad libitum fat group or on the reduced food intake group. And so a mouse living essentially in a cage made of cheese, if you will, like the mouse from Tom and Jerry. They will eat food all day long, all night long, whenever they feel like it. They nibble a little bit here and there. And that's essentially how all mouse studies are done everywhere in the world. Animals always have free access to food and water. In contrast, in the cohort of mice that get the pre-weighed food only once a day, they behave very different. And I'm imagining they're thinking, if I don't eat this food right now, a cat is going to come and chase me away, and I better eat it all. And in fact, that's what they do. Within 1 hour, they eat all the food. It's gone after 1 hour. And during this period of time, they would ingest the food, and the carbohydrates in the food would be converted to fats, or at least some of them will be converted to fats in the fat tissue. And then in the remaining 23 hours, they're essentially fasting. So they still have free access to water, but no more food is available. And what happens during fasting is that over time, this metabolic process of ketosis will kick in. And just as a quick physiology 101 recap, what is ketosis? So ketosis is a normal physiological process that we have evolved to be able to do. So during periods of eating, and especially if we're ad libitum eating, typically high carb food for most of us here in America, our cells in the body always have blood glucose available to them, and the blood glucose is the main energy source for most of the cells in our organs and tissues. Any excess blood glucose is taken up by the fat tissue and converted to fat. That's why if we're eating ad libitum, essentially starting at breakfast, continuing with lunch, continuing with dinner, having all kinds of snacks in between and a late snack at night, we're essentially doing this. We're having a high level of blood glucose. We're feeding our fat tissue, which keeps increasing over time. And that's the opposite of what happens during ketosis. So ketosis kicks in when we're fasting. And that is, again, a normal physiological process. So when our carbohydrate stores are used up, that is when the fat reserves kick in and the body fat will release what's called fatty acids, which can be taken up by cells in the body for energy. And some of the fatty acids are also converted by the liver into what's called ketones, another form of molecules that can also be taken up by cells in our body. And both these fatty acids and ketones essentially take over and provide the fuel for our energy needs. One of the ketones is called beta hydroxybutyrate, or BHB for short, and that will become important in a few slides from now. So this is essentially the normal physiological process of ketosis, and that's how we all evolved to deal with periods of fasting. And you can imagine in, way back then in caveman times, that's what happens to all of us, right? So we have food for a few days, and then it will take us, some time to catch another deer, if you will, and we can eat again. But during these times of fasting, we make, we kind of utilize our fat reserves for this process. Okay, and you can actually measure this in mice. In a certain type of metabolic cage, and never mind what the details are, but on this readout, if the value is about 1.1 or so, that means the mouse is burning carbohydrates. If the value is around 0.7, that means the mouse is burning fats. And in this experiment, these mice are fed every 24 hours. And you can see once the mouse is fed, it switches and burns carbohydrates exclusively. Once the carbs are used up, after about 12 hours or so, the metabolism crashes down and the mouse is using fat instead. And then the next time they're being fed, it goes back up and it goes back down. So this is how you can essentially cycle the metabolism in animals, and you can do the same in humans. So this is what's called time-restricted feeding, which will lead to what's called intermittent starvation. All right, okay, so we tested this in different animal models of PKD, and we used a rat model, a mouse model, and a cat model. So I'm going to show some examples. Typically, most people would argue there's no perfect animal model of PKD, and usually maybe the best one can do is just to compare different animal models. And what we tend to do is, if we get the same results and consistent results in more than one model, we tend to think that this will be predictive for the human disease. Okay. So and I'm trying to put the little pictures of what type of animal we used up here, so what we're looking at. So in this case, we tested time-restricted feeding on a rat model, and the way this was done is so here's our 24-hour cycle. The ad libitum control group has access to food the entire time. The time-restricted feeding, or TRF group, has access to food only for 8 hours. And it turns out that both groups of animals eat exactly the same amount of food, the same calories, so there's no caloric restriction going on. The only difference is really the timing of food ingestion. And you can see we're looking at the 2 kidney weight as a % of total body weight ratio. The cystic animals on the ad libitum diet have large kidneys. The cystic animals on the time-restricted diet have much smaller kidneys, and they're less cystic. And if we look at all kinds of different functional parameters and structural parameters, every single parameter is improved by just simply putting animals on this time-restricted diet. So this was very interesting. And we next asked, okay, how else can we induce ketosis? Another way of doing this is by using what's called a ketogenic diet, which is a very low carbohydrate and very high fat diet with moderate protein. So the protein content is not really different from the normal rodent chow, but the difference is very low carb, very high fat. And you can see the orange line here is actually the ketogenic diet. You can see if we put mice on a ketogenic diet, they're essentially burning fat the entire time because they never have any carbohydrates, so they can never get into this metabolic state of not burning fat. All right, so if we do this, and again, this is done in rats here, and now we're looking at the 2 kidney to body weight ratio. We can see the rats on the normal chow again have very large cystic kidneys. The rats on the ketogenic diet have much smaller kidneys, fewer cysts, and everything is again dramatically improved in these animals. And in this experiment, we're using the ketogenic diet, but now in slightly older animals, where the animals have already established cystic disease at the beginning of the treatment, at 8 weeks of treatment. And then we put them on a ketogenic diet until postnatal week 12. And you can see in the control animals, the kidneys stay cystic throughout the entire time. But in the animals on the ketogenic diet, we're actually decreasing the percentage of cystic tissue in these animals, suggesting that the ketogenic diet actually leads to a partial regression of the existing cystic disease. All right. The last type of experiment we tested here with regard to dietary intervention is acute fasting. So this is sort of the most dramatic, rapid induction of ketosis, where animals are just put on a complete fasting regimen with free access to water but no food. And we did this in mice, rats, and in cats. I'm just showing the cat experiment here as an example. This happens to be the first interventional study in PKD cats. This experiment was done by our collaborator Leslie Lyons at the University of Missouri. And the way this is done is by CT scans, so we can measure the total kidney volume and actually visualizing the kidneys, and you can see one kidney here of this particular cat, and I think you can see the cysts in these kidneys, and we can determine the total kidney volume based off of the CT scans. This was done for 4 different cats, and we measured the total kidney volume about 17 months before the beginning of the study, then immediately before the fasting, and you can see the difference here is essentially the progression of this particular cat. So this cat's total kidney volume increased by a certain fraction, and after 72 hours of fasting, remarkably, that's something I did not expect to happen. We actually saw a very strong reduction in total kidney volume in all of these cats, and noticed that this reduction in kidney volume is actually due to the sort of decrease in cyst volume in some of these cysts that we could identify. And we had very similar results in our cat and mouse model as well, suggesting that similar mechanisms take place. All right, okay, so this was truly exciting. and suggests that dietary interventions that lead to ketosis would have a beneficial effect in PKD progression. And we wondered whether the beneficial effect may be due to the ketones, and in particular to the ketone called beta-hydroxybutyrate, or BHB, which is one of the main ketones that are produced during ketosis. There were some good reasons to think this might be the case for us. So we tested this directly by supplementing BHB in the drinking water, and this is now done again in rats. So we're comparing rats with just normal water in the drinking water compared to BHB in the drinking water. And the results were fairly dramatic. You can see here a cystic kidney of a rat on just normal drinking water. This is a normal control kidney, a healthy kidney. This is a cystic kidney of a rat that ingested beta-hydroxybutyrate in the drinking water. And you can see here the kidney to body weight ratio. Again, the high values normally. And if we treat the animals with BHB, we see this very dramatic reduction. Now, remember, when Jacob got the very first kidneys as a result of this experiment, he came to my office, he's sitting in the back there, and said, "Hey, Thomas, I don't know if I believe this yet, but this is a very dramatic result." And he doubted his result, and he went back and double and triple checked everything, and it was in fact correct. This is essentially what we reported recently in this paper here. And the results have, of course, important implications. So they suggest that cells, the cis lining cells in PKD, are metabolically inflexible. They appear to depend on glucose, and they appear to not be able to metabolize fatty acids and ketones very well, that kind of replace glucose during ketosis. And importantly, this ketone beta-hydroxybutyrate, or BHB, appears to have a dominant effect in suppressing cyst growth. So what does this mean clinically? The clinical implications would, of course, suggest that ketosis may be a therapy for in PKD. That is something, of course, that would have to be tested in clinical trials to know this for sure. And because everything we have done so far are animal experiments. But it's, I think, very important to point out that fasting could be probably considered the oldest form of medical therapy, going back to prehistoric times. And you might know that fasting is a tradition deeply rooted in many societies and many religions. And many types of time-restricted eating, for example, have become relatively popular more recently. There's what's called the 16-8 diet, where people restrict themselves to only eating during an 8-hour window per day. There's the alternate day fasting diet that has become relatively popular very recently. And they are used, by even lay people to control diabetes, obesity, and so on. Ketogenic diets have also been used for a long time, and they're actually a therapy that have been used for about 100 years, almost in pediatric epilepsy, to suppress seizures in children. And that is a very effective therapy there. And in general, dietary interventions such as this are, of course, universally available, inexpensive, and they're safe for most people. I should, of course, point out in people with kidney disease, there's some reasons that some people may need to be careful with these types of diets. And as I mentioned in my at the very beginning, before anyone changes any diet or any supplement of or medical therapy, one has to always check with their doctor and be monitored. One general problem with dietary interventions is that they are difficult for most people to adhere to, and I think everybody is aware of this. If it were easy, there would essentially be no diabetes, no type 2 diabetes out there. And that's a very common problem, that people can adhere to a diet for a week or 2 or 3, but not for a long time. And in particular, in a disease like PKD, adhering for the rest of one's life, that is very, very difficult, which makes it very exciting that we found that just supplementing with this ketone beta hydroxybutyrate, at least in animals, appears to mimic the beneficial effects of dietary intervention. All right, okay, so one of the students in my lab, it turns out, is a fantastic artist, and she drew this cute picture here where, you know, this evil scientist is conducting an acute fasting experiment in mice, rats, and cats, and is revealing their diet for the day, which is nothing, but they do have free access to water. All right, good. So moving on to the next story, crystals, and this is going to be very brief, just a few slides, just to kind of show the bottom line. This is data that we published also very recently. Chances are that your doctor probably hasn't seen this yet, but there are some very important clinical implications. So the bottom line, I'm just going to show the bottom line of this paper. The bottom line is that, you know, in normal kidney tubules, you know, there's this fluid flow going right through the tubules, and you can think of them as little pipes. And this fluid that's going through them eventually becomes the urine, and that's just how kidneys work. That's how they're supposed to work. Kidneys always struggle with a challenge, and that challenge is that many of the compounds that go through these tubules tend to be insoluble and want to crystallize. And the most common ones are oxalate, which can form calcium oxalate crystals. There's also phosphate that can form calcium phosphate crystals. And there are purines that form what's called uric acid, which can crystallize in the kidney. And those come from, you know, essentially the diet, especially meat, and also in people with gout, there can be very high levels of uric acid. And all of these compounds can crystallize in tubules and in the urine. And this is essentially a normal occurrence. So normal people excrete millions of these crystals every day. But every once in a while, especially if you know there are too many crystals forming, it can happen that a crystal can occlude a tubule and get stuck in there. And it had been very poorly understood how these lodged crystals can be released and, you know, eliminated from the kidneys. And eventually these microscopic crystals can lead to kidney stones. So it's kind of an important research area. What we discovered is that these microcrystals that can lodge in kidney tubules lead to a widening of the kidney tubule diameter. So the tubules just, you know, get bigger over time, actually fairly rapidly. And that the purpose appears to be just to be able to flush out these crystals. Once they're flushed out, the tubules return back to the normal diameter. And this process happens in normal animals, normal people, and we would probably never know anything about it. However, in PKD, there appears to be a defect, and the dilated tubules cannot regress back to the normal diameters. Instead, they overshoot and they can form these cysts. So what we found is that if we challenge PKD animals with oxalate or phosphate, it worsens the progression of the disease. And that's shown here in 2 different rat models. In this experiment, we're subjecting the rats to what's called ethylene glycol in the drinking water, which leads to a high oxalate excretion for the kidneys and calcium oxalate precipitation. And you can see the animals on the normal water, you know, they have cystic kidneys, but if you increase the calcium oxalate burden, it worsens their disease. So they have larger kidneys and more cysts. And very similar results were found with a high phosphate diet compared to a control diet. So animals on a control diet would be here, animals on a high phosphate diet, and it's only 2 times double the increase in phosphate causes this fairly dramatic increase in progression of the disease. And these data are all they're published in this recent paper that I mentioned. So the question then is, so in this experiment, we're making animals worse, we're making the disease worse, which obviously we don't want to do ultimately in patients. So the question is then, what if we prevent kidney crystals from forming? Would this inhibit PKD progression? And the answer, amazingly, has been out there for about 20 years already. Some of you might know this literature. About 20 years ago, a scientist by the name of George Tanner, he and his wife Judy had this fantastic series of papers that they published in the scientific literature, where they found that citrate treatment, the citric acid, essentially, a very common compound, it's just a dietary supplement. They found that citrate is very beneficial in a PKD rat model. It improves the kidney function. It actually extends the lifespan of these animals. It almost doubles the lifespan. So these were very carefully conducted experiments, striking results. Unfortunately, this research didn't really lead to any clinical trials. It was never really followed up on. One problem is that at the time, these investigators couldn't really nail down the mechanism why citrate was effective. Citrate is also not something you could easily patent. So no company would have any interest in pursuing this. And this was essentially forgotten. So we have then in our paper sort of provided the mechanism why citrate was effective. And essentially what citrate does is it will suppress the formation of these microcrystals in the kidney. And we could actually show this in our paper as well. So we think that the potential treatment has already been out there for about 20 years, and it has never been actually tested in any clinical trials. So the take-home message here would be sort of asking the question, can we slow PKD progression by reducing risk factors for kidney stones? It's still an open question, but I think the data are compelling enough that every doctor out there should know that it would be important to limit foods that are rich in oxalate, phosphate, and purines, which each of them can, in excess, they can lead to the formation of these microcrystals, and our data would very strongly suggest that this could lead to the acceleration of disease in patients as well. Another important recommendation is to increase the water intake, and what that does is to essentially dilute these compounds as they're passing through the urine, and that will also prevent the precipitation of these microcrystals. Again, just a reminder, if you want to stay up to date on the research we're doing, I invite you to join my lab's Facebook group. The members of my team are listed here, and I want to highlight Jacob Torres, who has been the lead author on these 2 studies. That's it for me for the moment, and I'll hand it back to Nicole from the PKD Foundation.
Thank you, Dr. Weims. We appreciate the presentation. I am now turning this over to Dr. Dahl.
I think that the Dr. Weims's work has generated a lot of enthusiasm about looking at diet again. And I know this from my own clinic, where one of my patients sent me the Cell paper and said, "Hey, what do you think about this?" So this is an answer to her as much as sort of saying, okay, well, this is what we know about diet in PKD, and this is what we would recommend. And I also, before I get started, want to thank the PKD Foundation, because this is such a timely talk, and it seems pretty straightforward to put a webinar together, but in fact it's not, and I appreciate that effort too. So my disclosure, some of the other companies that I've worked for. And then today what I'm going to talk about is just reminding people that the dietary guidelines for kidney disease really depend on the stage of kidney disease. So we'll look at that. We'll talk about some of the popular diets that are out there, and then see whether those are in fact good diets for polycystic kidney disease. And then we'll look a little bit more at some of the unique characteristics of PKD cells and see if that can guide us a bit in food choices. And then, given Dr. Weims's work, how should we modify our dietary counseling? What should we do? And then I'll end with a few instructions, particularly for patients on tolvaptan and areas to get more resources. All right, so the first things first, so dietary guidelines for patients with mostly what I'm talking about is for patients with normal to nearly normal kidney function. For patients with advanced kidney disease, the diets become highly specialized and restricted. So in general, we're telling people with advanced kidney disease to follow a low salt, low potassium, low phosphorus diet, but without protein restriction, because we worry a lot about becoming patients with developing end-stage renal disease or end-stage kidney disease becoming malnourished, and protein intake is therefore very important at those very late stages of kidney disease. And then similarly for transplant patients, there are certain foods that may not be safe. So any kind of raw seafood or meat or poultry or an unpasteurized dairy product or raw or uncooked eggs may not be safe, just as unwashed raw vegetables or unpasteurized juices, eating from a salad bar may not be safe. So really think about what stage of kidney disease you may have or someone you're caring for may have, and then think about what dietary advice is appropriate. And when you're choosing, for example, to change your diet, know your kidney function before deciding whether that advice is correct. And as always, and I think Dr. Weims said this as well, talk to your team of providers and make sure that the changes you're making are really safe for you and are something good to do. So in general, for early stage kidney disease, so stage 1, 2, or 3 kidney disease, so this would be a GFR of 30 to 120 mils per minute. What we recommend is good fluid intake, good potassium intake, so lots of fruits and vegetables, limit salt, and here I mean sodium chloride, avoid excess protein intake, and then discuss caffeine or alcohol intake with your provider. And let's look at some of these data in a little bit, or guidelines in a little bit more detail. So there are some expert opinions or consensus statements that have been published in the literature. And usually the way these consensus statements are made is a group of people will get together and they'll look at the body of literature in a particular topic. So for example, protein intake and PKD. And then they'll grade that material on the basis of whether the evidence first is good or not. So for the evidence, grade A is high quality evidence. And then they'll make a recommendation based on that data. So a strong recommendation or a weak recommendation. And I'll show you what some of those things, what some of those look like. So there are 3 areas or 3 papers that have come out that have really talked about diet and what particular consensus is. One of them is from KDIGO, which is an international organization that looks at global outcomes in kidney disease. So that was published in 2015. There's a Canadian expert consensus that was published in 2018. and a European AD-PKD multidisciplinary position statement that also came out in 2018. And here are some of the summary statements here. So first, if you look at protein intake, this is what is recommended for adults. So 0.8 grams per kilogram per day. And that's the dietary reference intake, or DRI, that's published from the Food and Nutrition Board, which is part of the Institute of Medicine, National Academy of Science. And so here, KDIGO in 2012 said for patients with kidney disease, avoid high protein intake, and high protein meaning more than a gram per kilogram per day. So a 60 kilogram person should be eating about 60 grams of protein a day, but certainly not a lot higher than that, certainly not a lot higher than about 1.3 grams per kilogram per day. After the GFR falls, the protein intake should be about 0.8 grams per kilogram per day, so normal protein intake. And here's a cautionary statement. So protein restriction should be monitored for those with high total kidney or liver volume, because those patients may also be at risk for developing, becoming malnourished. The Canadian consensus statement did not make a recommendation about protein. The European said low protein diet where appropriate, but that people with protein restriction who choose to do that should be monitored carefully. For water intake, KDIGO said to increase water intake. There was no recommendation in the other two guidelines. Salt is different, so everyone is told to follow a lower salt diet. KDIGO recommended a sodium restricted diet. The Canadian guidelines suggested to follow the same salt restrictions that are in the hypertension guidelines, and in particular for people on tolvaptan to limit sodium intake to about 2.4 grams or 2,400 milligrams a day. And the European statement also said to follow a low salt diet. And some of you have heard caffeine may be bad in PKD. So here the recommendation is to avoid a high caffeine diet. And here there's a recommendation simply to control caffeine intake. KDIGO also recommended monitoring, and the monitoring was based on a 24-hour urine. So KDIGO says avoid high salt or sodium, don't smoke, eat a healthy diet, keep hydrated, moderate alcohol intake, and exercise. And encourage patients to self-monitor blood pressure and weight. So again, that's easy to do, right? To monitor blood pressure and weight. The Canadians said there was no compelling evidence to support the use of protein restriction or increased fluid intake, but rigorous blood pressure control is important. And the European consensus statement said that patients should be advised on the expected antihypertensive, so blood pressure benefits of lifestyle adaptation, including weight control, exercise, and a low salt diet. And that there was no good evidence that a protein limited diet slowed the progression of AD-PKD. And so here is another consensus or another expert opinion statement, this time from the Mayo Clinic. And what they're recommending, and here you can see the grades of evidence. So grade 1 is a strong recommendation, but C means the evidence is not high quality. So here you can see for sodium, they recommend moderate sodium restriction, and moderate, not severe sodium restriction, because there's some data that with very severe sodium restriction, there can be some poor outcomes, especially for people who live in hot climates or are runners or have bowel disease where they may tend to get volume depleted. Hydration, what they recommend is spacing out hydration moderately over the course of 24 hours. This means during the day, this means at bedtime if you're waking up, and at nighttime to have extra fluid. And they have a specific goal here to maintain a urine osmolarity less than 280, which means to always be making a dilute urine. So they recommend monitoring 24-hour sodium and monitoring the urine, particularly in the morning, to see if that urine is dilute, and modifying a water prescription to fit what your daily solute intake is. And we'll come back to that towards the end of the talk, and I'll show you what that looks like. Here is the protein guideline. So normal protein intake, about 0.8 to 1 gram per kilogram of body weight, moderate phosphate restriction, and then bicarbonate as we do for everyone with chronic kidney disease, and caloric intake to maintain a normal body mass index. Okay, so some of you may have heard about a diet that we'll talk more about called Dietary Approaches to Stopping Hypertension. And I'll show you what that diet is in a minute, but for here, right now, what I want to show you, I'm sorry, is a couple of data points that support use of the DASH diet. So most of you know about the HALT PKD study looking at blood pressure control and the effect on either change in kidney function or change in kidney volume. And what they found was that people who had less sodium intake, that led to less of an increase in total kidney volume or less of an eGFR decline in a later population of patients. So study A was the younger patients who were getting kidney volumes measured. Study B were the older patients who were getting GFRs measured. There was a correlation too between potassium intake and total kidney volume. So the higher the potassium intake, the less increase in kidney size and the less decline in kidney function. And then from another NIH-sponsored study, from the CRISP study, there was an association between urine sodium excretion, so a daily urine sodium intake, and total kidney volume. So those patients who had a higher daily sodium intake had a higher total kidney volume. So suggesting that simple things, sodium and potassium intake, may be affecting the kidney size. And here, urine, in the CRISP study, urine osmolality was also important, suggesting that volume may be playing a role in kidney size. So the diet I'm talking about stands for Dietary Approaches to Stopping Hypertension, also called DASH. So what is this? It's a diet that's rich in fruits and vegetables. It's moderate in low-fat dairy products. It's low in animal protein, in sodium, in sweetened beverages, and in things that form simple carbohydrates. So bread, potatoes, rice. It's rich in whole grains. And it was developed by the NIH for treatment of hypertension. And you can think of it as a high potassium, low sodium, and lower phosphate diet. So how does DASH do? Well, turns out the US News and World Report ranks diets the same way they rank schools or rank hospitals. And what you can see here is the DASH diet does pretty well. So it's #2 in best diets overall. It's #3 for heart healthy diets. It's a good diet for diabetes. It's a good diet for healthy eating. It actually does pretty well in one of the easiest diets to follow. So where it does not do well is it's not great for fast weight loss. So let's look a little bit more carefully at what it is. So I've just cut little snippets of what the guidelines look like, but you can go here to this website and see it in more detail. So first, they determine what the daily calorie needs are. This is for someone who's sedentary, but they have other tables for people who are active or moderately active. And then based on that caloric need, it tells you how many servings of a grain, vegetable, fruit you can have. And you know, sometimes people say to me, well, okay, I get it. This is what you're telling me to eat, but I still don't know what to buy when I'm at the grocery store. And so here you can see what a typical meal plan might look like for someone on the DASH diet. So this is a 2,000 calorie diet, and I'm just showing you what the breakfast and the lunch options are here. And one thing I would like to point out here is this half cup of tuna is counting as 3 servings of meat or fish or poultry. So sometimes that portion control becomes really, really important in terms about thinking about this. But this is how it works. So there's a fairly hefty amount of meat in lunch. So the dinner ended up being a non-meat containing dinner. It was a zucchini lasagna. But so this is the typical nutrient intake for this kind of diet, about 2,000 calories, high in potassium, high in fiber, and lower in sodium, about 2,000 milligrams of sodium. So I'm going to switch for a minute and talk about now why it's important that we think about PKD from an energy and metabolism perspective. So it turns out the reason for this is that PKD cells are very, very sensitive to energy metabolism. And the reason for this is as follows. So in general, inside a cell, inside every cell in our body, there are 2 ways of producing energy. One is a low output but fast process called glycolysis, and the other is a slower but high output process called, here it's called oxidative phosphorylation. And what happens is, so either of these produce energy. Glycolysis produces a little energy but quickly. Oxidative phosphorylation produces a lot of energy but over a period of time. PKD cells have an increased sensitivity to using glycolysis. They prefer this pathway and tend to have a defect in oxidative phosphorylation and have altered mitochondrial function. So this is a mitochondria. This is where oxidative phosphorylation is happening. And so glucose is entering the cell here through its glucose transporters. It's going through glycolysis. That generates pyruvate. Pyruvate then goes inside the mitochondrion, and it's then oxidized or burned inside the mitochondrion to generate those things that then turn this cycle on and produce lots of ATP or energy for the cell. So what researchers have realized is because PKD cells are very sensitive to this pathway, to the glycolytic pathway, there are now new areas for therapy. So why is it true that they're so sensitive? So PKD is caused by a defect in a gene that encodes for polycystin 1, which is this protein that's shown in the blue, or PKD2 encodes for polycystin 2, and this allows calcium flux into the mitochondrion. The calcium is important for oxidative phosphorylation. If these proteins aren't there, then this whole process shuts down and the cell becomes very dependent on glycolysis. And that then leads to this generation of novel potential therapeutic targets. So Dr. Weims spoke a lot about dietary restriction. You may have heard of trials ongoing with metformin and pioglitazone. There's some very interesting new data using 2-deoxyglucose as a potential therapeutic area. Fenofibrate, which is already used for cholesterol, regulation of cholesterol metabolism. And so there's a lot of interest here in looking at metabolism, looking at glycolysis versus oxidative phosphorylation, and the role of mitochondria in disease. So what do we know so far? We know that glucose metabolism is altered in PKD cells, and that the cells are very dependent on aerobic glycolysis. This is called the Warburg effect, and that these cis cells favor a faster, less efficient form of metabolism. And that pathways regulating glycolysis also impact cyst growth. Ketogenic diets, which Dr. Weims described, mimic carbohydrate starvation. Calorie restriction also leads to increased ketone production and reduced growth of kidney cysts. There's no data showing that omega-3 fatty acids or soy protein show any benefit in disease progression. So then how does the keto diet compare? How does that diet help us in terms of thinking about the right diet for PKD? So first, I'm showing you the top 3 diets by the US News and World Report. So the Mediterranean diet is number 1. I spoke in detail about the DASH diet, which ranked number 2. The flexitarian diet, which is a predominantly vegetarian diet, is number 3. This is just that Mediterranean diet pyramid. So activities on the bottom, lots of fruits and vegetables for the largest part of it, and then things like meats and sweets at the very, very top. This is the keto diet, so it does not rank well. It's 33rd for best overall diets, 12th for best weight loss diet, 39th for easiest diet to follow. Where it does rank well is for fast weight loss, right? So this will help you lose weight quickly, but this is a diet that's very high in fat and very low in carbs. So what are some specific concerns that we would have with the keto diet in PKD? It leads to higher acid and lower alkali in the urine, which may further increase the tendency to form kidney stones. And Dr. Weims talked about the importance of citrate in helping to prevent kidney stones. We know that cardiovascular disease is prevalent in people with ADPKD, and a high-fat diet may therefore increase the risk of atherosclerotic or coronary artery disease. And this diet may have a high osmolar load, which could be associated with higher vasopressin levels if fluid intake is not maintained. And vasopressin, we know, is critical for cyst growth. So how do we then incorporate this new data into counseling for ADPKD? So I think some things are straightforward that all of us could agree to do. Simple sugars and carbohydrates that break down into simple sugars should be minimized. Complex carbohydrates and whole grains are preferred. Not all animal studies lead to positive results in human clinical trials, and I think Dr. Weims highlighted this when he showed us the mTOR studies initially, but then when they tried those mTOR inhibitors, sirolimus or everolimus, in people, those studies were disappointing. And therefore, it's better to wait until there's additional information available, either for drugs that manipulate glycolysis or on the efficacy of keto diets. But what about the other things that he talked about? What about something like intermittent fasting? And I think intermittent fasting may be safe for someone with early kidney disease, again, that's stage 1 to 3A, as long as there's no medical prohibition against it. You don't have diabetes, you're not expecting, you're not nursing. I would say that intermittent fasting is a hard diet for people who are very physically active, right? So if you're a runner or something like that, it may not be an appropriate diet. Right now, there's no clinical trial data to suggest that any supplements are beneficial. And so really supplements should be used only with a great deal of thought and discussion. Everyone would agree that maintaining an ideal or near ideal body weight by the appropriate use of a heart-healthy diet and exercise should be encouraged. And we would all encourage people to do that. I'm going to quickly just talk about two interesting thoughts now about how to adjust fluid and diet together. So this was a very small study carried out looking at whether a low osmolar diet had an effect on vasopressin. So most of us know that vasopressin is a hormone produced that can increase cyst growth, can accelerate cyst growth. So here they randomized people to water and a low osmolar diet, low sodium and lower protein diet, and adjusted the water intake so that they were always making a dilute urine. And they compared those folks to people who got no intervention. And what you can see is that those people who had the lower osmolar diet had lower plasma copeptin levels, suggesting that they had lower vasopressin effect compared to those people who were eating the more regular diet. So with intervention, plasma copeptin levels and 24-hour urine osmolarity declined. That's what I'm showing you in the bottom table. And then the final word, if you're on tolvaptan, it's important to remember that urine output is going to be driven by osmolar load. So what does that mean? So here is urine output, and then this is the amount of osmoles someone is eating in a day. So the more osmoles they eat, the more urine that they produce. And that's really being driven by sodium. So the more sodium you have, the more urine output you'll have. And from urea, which is a breakdown product of protein. So the more urea you have, the more urine output you have. And so here the lesson for the folks on tolvaptan is really to limit urine volume. It may be beneficial to limit sodium intake. And particularly that last meal of the day, you may want it to be a lower sodium, lower protein meal, just so you're not as uncomfortable in the evenings. And with that, I'm going to say that there are a lot of really well curated resources online. So one of my favorite nutrition counters is from the American Association of Kidney Patients. And for each food, including for some fast foods, it will tell you the potassium, sodium, and protein content. The National Kidney Foundation has some nice data for the DASH diet. The PKD Foundation, obviously, they have some great data, including a great cookbook. And then about 10 years ago, Judy Ehrlich, who's the head of the New England chapter of the PKD Foundation, gave me this book, Food Rules, An Eater's Manual. And it's a very short and easy book to read, but really captures a lot of the things that we were talking about. So with that, I know we're well over time. I'm going to stop, and Nicole, let us know if there are time for questions.
Thank you, Dr. Dahl. We appreciate all of that information. We do have quite a few questions, so I would like to take a few minutes to ask some of these questions. So I'll jump right in. The first question we have is, I think we would ask Dr. Weims to respond to this first. Have you researched, or do you have research on diet and polycystic livers?
I don't believe we have any data on livers at this point.
No, we never observed any cysts in any of the animal models that we are using.
Right. So this all depends on the type of animal models we would use. Only some of them have liver cysts, some don't. And the ones we have used so far, they don't have liver cysts, at least not as significant as one would need it. So currently we have no information on that. But that's a really good question. Yeah.
Thank you. And Dr. Dahl, would you like to respond as to how diet might impact polycystic livers?
So I think for polycystic liver disease, it depends on whether the livers themselves are quite large. So if they are, we sometimes recommend having smaller meals where there's more frequent meals, so that sometimes people can have an early sensation of fullness with very large livers, and so we try to use that strategy to avoid some of the bloating sensation that people might feel. But otherwise, I would say the same heart-healthy diet that we've been talking about for polycystic kidney disease is the right diet for polycystic liver disease.
Okay, thank you. Next question, would ketosis still be effective in kidneys with low function? So for example, an eGFR of 10.
Mm-hmm. Well, you know, obviously we don't know the answer. I think, you know, the lower the function, the more careful one has to be with everything. And I'm sure Dr. Dahl would say the same thing. So especially with dietary interventions, they tend to be safe in normal people with healthy kidneys. I would have no concern there really. As you know, the more kidney function is compromised, the more the equations change. So one would have to be very careful there. We don't, I mean, based on our animal studies, it looks like, at least in these animals, that something like a ketogenic diet actually causes regression of existing disease. Whether that translates into the clinical practice, that is yet to be seen.
Thank you. And Dr. Dahl, would you like to respond?
I would like to respond. So I would say someone who has a GFR less than 15, so stage 5 CKD or ESRD, it would be very inappropriate to try ketogenic diet at that point. We worry a lot about malnutrition in those patients. We worry already about metabolic acidosis because the kidney also generates bicarb, and that would be impaired. And so I think that is not the right time to try a diet like this. We would really advise against that.
Okay, thank you. Our next question is, have you worked with doctors in other areas looking at ketosis? So for example, cancer, epilepsy, diabetes?
We have not directly worked with them, no. I'm aware of some, you know, a lot of the work that's out there, and it's fascinating work. As you mentioned, you know, even Alzheimer's disease, for example, there's a lot of very interesting work coming out of there. And, you know, there's clinical studies being conducted, and I think a lot of the results from those studies we would want to take a really good look at to see how this can inform our own clinical trials that we're planning right now. Yeah, that's all I can say.
Okay, Dr. Dahl?
No, I have not worked with other subspecialists or other areas. I have not, no.
Okay. And I believe this was covered very well, Dr. Dahl, when you were speaking, but we did get this question a few times, so I'm going to go ahead and ask it if there's anything else you want to add. How might a keto diet impact patients at risk for cardiac events?
So a keto diet or a high-fat diet may be quite detrimental to someone with cardiac disease, because we worry that would potentially make the atherosclerotic disease process worse.
Okay. Dr. Weims, what about, did you study what happens when animals resumed the non-keto diet? Did the benefits stop or reverse?
Mm-hmm. That's something that Jacob here is working on right now. So the question is, you know, whatever benefit we see if we put the animals back on the normal diet, how quickly does it catch up, if at all? So we have nothing to report there yet. That will be you know, in one of our future papers, those results.
Okay. What is next to understand how the keto diet impacts human PKD patients?
So, as I mentioned, so we're planning a clinical trial with our colleagues, of our clinical colleagues, and the purpose of this initial trial is to just look at the feasibility of ketogenic diet versus time-restricted diet, to just answer the question in a PKD population. How easy is it for a patient to adhere to these diets? Are there any immediate effects in a short-term study? And the purpose is really not to look at efficacy because that takes a much longer time. The purpose is to inform the design of a subsequent larger efficacy trial to then see, do we actually see a beneficial long-term effect of these diets? So that's in progress. We're working very hard on this. And I would say stay tuned for results.
Okay, thank you. Dr. Dahl, any comments for that question?
I think really that question is an important one because we really need to see the clinical trial data to know whether this is something that really has wider implications for PKD patients.
Okay, thank you very much. And I want to thank everybody for hanging in here with us. I know we've gone over time. I feel like that's all the time that we have for questions. And I want to thank Dr. Weimbs and Dr. Dahl for answering the questions and for all the information that you've provided for us. This is a very timely topic, and we really appreciate our presenters for assisting us with this resource and also doing it as quickly as we did. So thank you so much for that. I did want to share with you that we are having a PKD Connect conference coming up. This conference is our national conference bringing all members of the PKD community together. So we hope that you'll save the date and join us next summer. You'll be able to meet with patients, family, and friends, learn about disease management from medical professionals, catch up with the latest research, and explore PKD advocacy. Registration for the conference will open in January of 2020, and we hope to see you in San Diego on June 19th through the 21st, 2020. The PKD Foundation appreciates the opportunity to provide you with the best possible education. After the webinar, you will receive a very brief survey. We appreciate your feedback and will use your responses to develop future resources and programs. When you complete the survey, please include additional topics that you would like us to address in future webinars. Also, please send additional questions or feedback to pkdconnect@pkdcure.org, and a member of the PKD Connect team will get back to you. On behalf of everyone at the PKD Foundation, thank you for joining us.
Thank you.
Bye.
Good night, everyone.